Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Sadia Noor, and I am Joint Secretary PSA Karachi, and I welcome you all, the participants and Madam Asiya, to this lecture on behalf of PSA. And kindly just note one thing, that the mode of uh, speaking and delivering the lecture is English, and it should be maintained during the lecture. And if anyone has any question, kindly comment in the chat box, and we will be taking the questions at the end of the lecture. So I welcome Dr. Asiya. She is consultant at Doctors Hospital and Medical Center, Lahore, call associate. Madam, please.
Should I start? Okay. Assalamu alaikum, everyone, and a very good evening from Lahore. And a big thank you to PSA for giving me the opportunity to speak on a subject that is very close to our hearts. I have just taken the liberty to slightly modify the topic, which is blood transfusion in obstetric patients and overview. Okay, we start here. Now, let me give you the background of the problem. As you all know, that anemia in pregnancy is defined as a hemoglobin level of less than 11 grams per deciliter, and this should be during the first and the third trimester of pregnancy. Whereas if it is less than 10.5 grams per deciliter during second trimester of pregnancy, we have to do some interventions. So this is generally the anemia classification that is given globally. Now, a high percentage of pregnant women have anemia of varying severity. So the pre-existing anemia, it increases the need of blood transfusion during maternal obstetric hemorrhage and with its associated risk. Patient blood management strategies, which we are going to discuss afterwards, can reduce the risk associated with maternal obstetric hemorrhage and blood transfusion. So this next slide, it shows the WHO global anemia, WHO global anemia estimates, which were given in 2020-25 edition, and it reveals that anemia remains the major public health problem in women of reproductive age, that is from 15 to 49 years. The WHO has emphasized to achieve a 50% reduction in anemia by the year 2030. And only there are 18 countries who have achieved this target, which comes to only 10% of the global women population of reproductive age. In this, study, you can see that our country, Pakistan, you can see the arrow, it stands amongst the, in orange, near to Bangladesh, and this signifies the Southeast Asian population. Next is that the Global Anemia Estimates 2025 also emphasized that the anemia who's doing this? ये कैसे आगे जा रही है? Sorry. So global estimates in women pregnancy status. So what's happening is this target is only achieved by 18 countries, and the rest of the whole world is lagging behind. They are off the track. and they haven't achieved 20 till now. And millions of women of reproductive age and children currently experiencing fatigue, lethargy, shortness of breath due to anemia, debilitating symptoms, well-being and productivity of human capital and women. Now, this is a comprehensive systemic review of meta-analysis, which was published in Maternal Child Health Journal in 2022, which shows that overall 36.8% of anemia occurs in pregnant women. Mild anemia is present in 70.8%, and the highest prevalence which is observed is in the third trimester of pregnancy. This study was published in Maternal Child Health Journal in 2022. And this study next. Yes. Now the anemia in Pakistan. What is our perspective? WHO defines anemia as hemoglobin level of less than 11 grams per deciliter, whereas 90.5% of the population of pregnant women in Pakistan had anemia, and out of which 75% has mild anemia. That is, their hemoglobin is from 9 to 10.9 grams per deciliter. Moderate anemia is present in 14.8% of the population. They have a hemoglobin value of less than 7 to 8.9 grams. Whereas severely anemic patients are 0.7% and their hemoglobin is less than 7 grams per deciliter. This low hemoglobin not only impacts the health of the mother, but also accounts for low birth weight of infants. So, anemia and red blood cells. A nationwide analysis of more than 6 million cases, which were conducted from 2011 to 2020. And in this study, they found, this study was done in Germany, and it was done in more than 6 million cases. And in all the women, they analyzed the rate of anemia, peripartum hemorrhage, and the use of blood products and complications were analyzed. And it was seen that anemia was present in 23.74% of the population. And they divided the patients into two groups. One was the ones who were given transfusion, RBC transfusion, and the other was the group which were not transfused. The RBC transfusion group was constitute 1.23%. And they have shown that it was observed that PPH was more prevalent in the transfused group, which was 41% versus the 4.35% in the non-transfused group. Excuse me, मुझे the pictures आ रही हैं सबकी. I don't know.
Dr. Asiya, maybe you can just slide those the icon or the tab on the right side. जी, उसको वो करें तो वो probably it will.
चलें, ठीक है. Thank you. So So in those patients, observed that PPH was more prevalent in the transfused. Similarly, the hospital length of stay was longer, 127.5 versus the 87.8 hours in the non-transfused group. So they concluded that high anemia prevalence and increased risk of transfusion highlight potential for patient blood management strategies. These strategies, when applied, can reduce the transfusion and maternal morbidity. Next comes the maternal obstetric hemorrhage. And we know that it is the leading cause of maternal morbidity and morbidity. And the death mostly occurs in the resource-limited settings like Asia and Africa, mostly. So the definition given by WHO of PPH is a blood loss more than 500 ml. The American College of Gynecologists describes it at a blood loss more than 1000 ml within 24 hours with or without hypovolemia. And the Royal College of Gynecologists describes it as major PPH, which is from 1 to 2 liters. And they call it severe PPH if it is more than 2 liters. Now we come to the 4 T's of obstetric hemorrhage. I think so. You all must know that the tone means uterine atony, which usually occur during the postpartum and which cause a loss of blood and needs transfusion requirements. And when the uterus fails to contract after birth. Next is the tissue, when there are retained placental fragments or membranes after delivery. They can also cause obstetric hemorrhage, trauma, lacerations or injuries to the birth canal, which includes the cervix, the vagina, the perineum, or uterine rupture. Next come the thrombin coagulopathy or blood clotting disorders. So the World Health Organization, in a policy brief, urgently said implementation of patient blood management strategies, especially in obstetric patients. What these strategies do, they aim to minimize the transfusion. And how come? By prediction, how much blood is lost, correction of prenatal anemia. That means you have to nip the evil in the bud. So correction of prenatal anemia is more important. Prevention and reduction of hemorrhage during deliveries, the delivery of the 3rd stage of labor, delivery of the baby, less instrumentation during delivery, and limited use of transfusions, decreasing the transfusion triggers, and optimizing postpartum anemia treatment. Now come the 3 pillars of patient blood management. The 3 pillars of patient management are: number 1, you have to do the detection, then the management of anemia during the 1st and 2nd trimester of pregnancy. Their iron deficiency should be corrected. So this is done by routine detection, evaluation, diagnosis as to cause and management of anemia, iron deficiency as clinically appropriate to the diagnosis. This includes treating the underlying causes, Anemia treatment may include the use of pharmacological agents and nutritional supplements. Next pillar for patient blood management is minimization of blood loss and optimization of coagulation. Systemic and timely identification and management of the risk factors for bleeding and minimizing of blood loss and the impact of coagulopathy that results in bleeding through anesthesiologic, hemostatic, surgical, and other appropriate measures and interventions. Now comes the pillar 3, leveraging the optimizing the patient-specific physiological tolerance of anemia. Use of all appropriate measures to leverage and optimize the patient-specific physiological tolerance of severe anemia. So, the patient blood management in pregnancy, the strategies what we do is, during pregnancy, first of all, we screen for iron deficiency and anemias, any other causes, and treatment is done according to the trimester and the severity. Screening and treatment of coagulation disorders, measurement of fibrinogen, which is very important, especially in the late pregnancy. Next come the second stage, the delivery of the baby, the transfusion. If bleeding occurs, transfusion and coagulation algorithms should be followed, and point of care diagnostics. We will discuss them afterwards, and cell saver. So after the delivery, that is the postpartum period, screening and treatment of iron deficiency and anemia, where clinically indicated. So as WHO has said, there is a repetition of deficiency and correction of anemia, not only during the first or second trimester, also during the postpartum period, where it is clinically indicated, and also close monitoring of the blood loss. Even after the delivery, 24 hours or 40 hours, patient can bleed. So we have to have a rationale for restrictive use of allogenic blood products. This is the flow chart which shows the therapy of anemia and iron deficiency in pregnancy. So first of all, screening of anemia and iron deficiency is done during pregnancy. Isolated iron deficiency is corrected by oral iron. And if it is not successful, then intravenous is given. Iron deficiency anemia, if it persists in pregnancy, especially during the first and second trimester, it is corrected by giving oral iron. And similarly, if it's not successful, then we have to move to intravenous iron. Next, correction of iron deficiency anemia is done in second trimester. And if it is severe anemia, then you don't go to the oral, you straight away go to the intravenous iron therapy. Whereas in the third trimester, if the patient is still anemic, you will jump to intravenous iron. And this is the way you are going to build up their hemoglobin so that the patient is prepared for the delivery of a healthy baby. And if screening for anemia is without iron deficiency, further diagnostic and therapy is done. This was a study which was conducted in Western Australia, patient blood management program. And it was this study, patient blood management program, has got key program indicators. And what were those indicators? They looked for the preoperative anemia, and they found that with the different intervention, the preoperative anemia, it reduced from 21% to 14%, and the decrease in pre-transfusion hemoglobin. They decreased the transfusion trigger from 7.9 grams per deciliter to 7.3 gram per deciliter. And this decrease improved the patient's outcome. And also they gave single unit transfusion. They increased it from 33. That is, single unit transfusion was increased from 33% to 64%, which improved the patient blood management. Next comes the reduction in the units of blood transfused. So with the interventions, they reduced the unit of blood transfusion from 41% decrease in red cell blood transfusion. Next, the plasma, 47% decrease was seen, and 27% decrease in the platelets. So the overall, the product cost savings, the overall 6-year study period, the blood product cost, which they saved was $18.5 million. And the activity-based cost, which the hospital cost of administering a transfusion was $80 to $100 per million. Now the improved patient outcomes. Mortality was reduced by 28%, infection 21%, strokes 31%, and the length of hospital stay, that was decreased by 51%. So now comes another study which was done in BGA education in 2022 regarding major obstetric hemorrhage. They published a protocol which I'm going to share. This is the protocol. It looks very crowded, so I have split this into, yes. So for major obstetric hemorrhage, a call is sent, they mobilize when there is a blood loss of more than 1,000, and there are signs of hypovolemia. They mobilize obstetric anesthesia department, call for senior help, initiate massive transfusion protocols. Lab and transport staff is alerted, and immediate issuance of blood components. Similarly, side by side, immediate resuscitation is done, airway assist, breathing by giving 100% oxygen, wide bore IV access is taken, and warm fluids, crystalloids are given if blood is not available. If blood is available, then it is transfused. Next intervention which is done is by the obstetrician clinically. They do the external uterine massage, bimanual uterine compression, active warming. If uterus is contracted, then they transfer, and the patient is still bleeding, they transfer the patient to the theater. Along with that, pharmacological interventions are done, which include the uterotonics and tranexamic acid. We will talk about it afterwards. And blood component therapy, which includes the packed RBCs, the FFP, cryoprecipitate, the fibrinogen, and platelets. Side by side, the assessment and investigation of bleeding, which includes the tests like cross-matching, full blood count, coagulation, level of fibrinogen are more important, urine tests, the liver functions, the QBL, the point of care, echocardiography, thromboelastography, which includes the point of care hemoglobinometer and consider invasive monitoring if required. When the patient comes to the operation theater and the patient is still bleeding, consideration for interventional radiology is done, and selective endovascular, either balloon occlusion or embolization of the uterine artery or the balloon occlusion of the ureters can be done. Then when you transfer the patient to the operation theater, EUA examination under anesthesia is done, and if uterine inversion is there, it is reduced, genital tract trauma is seen. Intrauterine balloon tamponade can be done if still bleeding is not stopping, then hemostatic compression sutures can be done, or uterine artery ligation, and still bleeding is not stopping, then hysterectomy can be done to save the life of the mother. And this patient, if stable, is then shifted to a high dependency unit or to the ICU. Now come the transfusion strategies. So how do we know that which transfusion should be done, should we give? So there are transfusion strategies are ratio-based versus lab guidance. In ratio-based, you give a fixed ratio of RBC, plasma, and platelet, 1:1 ratio. But this is obsolete now. The lab data was used to be guided by the traditional blood sampling, which was drawn from the patient and then sent to the lab for results, which can take an hour or so. Therefore, now they have introduced point of care testing, which is called TEG. As you can see, the graph in TEG, which shows coagulation and fibrinolysis. It gives you real time. It gives you real time values. Continuous non-invasive, at the top you can see it is the continuous non-invasive hemoglobinometer, which tells the level of hematocrit and hemoglobin continuously. Lower down is the prothrombin time monitor, which you can check the PT, and this QLabs Fib is the level of fibrinogen, which checks, and you can then transfuse the factors or components according to the lab given, so that unnecessary transfusion is not done. And now next comes the current opinion in anesthesiology. They give the current concept in the use of cell salvage in obstetrics. So severe maternal hemorrhage is the most leading cause of maternal morbidity and mortality. So the use of cell salvage in women with high risk for maternal hemorrhage is strongly recommended. And there is evidence that the routine use of cell salvage in obstetric is beneficial as well as effective, and at least for training. So intraoperative salvage, which was used to be thought, it does not increase the risk of amniotic fluid embolism. Its use is most cost-effective and beneficial in women with risk factor for maternal hemorrhage. Next. Yes. Role of fibrinogen. fibrinogen plays a very crucial role in the formation of a fibrin and platelet clot and arresting the bleeding. The low fibrinogen is usually the first hemostatic indicator of coagulopathy following postpartum hemorrhage. So women who have got a plasma fibrinogen level of less than 2 gram per liter and are continuously bleeding, they represent a high risk group, which is associated with both progressive hemorrhage and the increased use of blood products and invasive procedures. So it is the fibrinogen level should be checked, and if it is done by the point of care testing, and if you give them fibrinogen, the bleeding stops then immediately. And fibrinogen replacement is only done if it does not affect the bleeding when the level of fibrinogen is more than 2 gram. So it's better to check the level. Otherwise, it will not affect the bleeding if the levels are more than 2 grams. Now, there was an international study by the name of Women's Trial. This study was conducted to assess the effect of early administration of tranexamic acid on death, hysterectomy, and other relevant outcomes in women with PPH. And the role of tranexamic acid is when it is given as soon as possible after the bleeding starts, and it should be repeated if the bleeding does not stop. It can be repeated 30 minutes after the initial dose. So now the Journal of Maternal and Fetal and Neonatal Medicine. They did a study on whole blood transfusion, which they showed that it reduces the overall component transfusion in cases of placenta accreta spectrum. Whole blood may be considered as the initial resuscitation with similar post-op outcomes, fewer component transfusions, and fewer donor exposure. As placenta accreta spectrum cases continue to increase, the development of novel approaches to patient will be required to continue to optimize outcome for complex surgical cases. The post-operative outcome which were seen were if the patients were given whole blood. When the patient was given whole blood, the maternal surgical morbidity outcome composite was 7 with the whole blood, 12 the patients who got the component therapy. Transfusion units more than 4 units were given in whole blood population and 10 with component therapy. ICU admissions were more in the component therapy group as compared to the whole blood group. The intraoperative acidosis was 2 in the whole blood group, and in the component therapy group was 3. The length of hospital stay, more than 4 days, was in whole blood group and 6 in the component one. The ICU length of stay was 0 in the whole blood group and 1 in the component group. Infection were nil in the whole blood and 1 in the component group. So now the take-home message. There is an increased prevalence of anemia in the pregnant women, and this increases the need of transfusion in cases of maternal hemorrhage. The WHO and multiple national guidelines, they recommend patient blood management strategies to reduce the need for blood transfusion in obstetric patients. The strategy include early management of anemia and a structured approach to manage obstetric hemorrhage. A structured patient blood management approach, it resulted in better maternal outcomes, reduced cost as shown in multiple studies, and a healthy neonate. So the woman about to become a mother or with her newborn infant upon her bosom should be the object of trembling care and sympathy wherever she bears her tendon burden or stretches her aching limbs. And God forbid that any member of the profession to which she trusts her life, doubly precious at that uneventful period, should hazard it negligently, unadvisedly, or selfishly. This is the saying by Oliver Wendell Holmes. Thank you very much, and questions are welcome, please.
Thank you, madam. You can all write your questions in the chat box, and meanwhile we can ask. We have seniors out there, and if anyone want to comment or any feedback, kindly please share. We have Dr. Sadaf Mushtaq. Can you please say a few words?
Assalamu alaikum. Thank you, Dr. Sadia, for the opportunity. Probably you don't know that I'm working with
Are
Dr.
working
Asia for
together.
yes,
Yeah, for a long time.
and a couple of days ago, I was recalling a case which I was conducting under supervision of Ma'am Asiya. Ma'am, probably she can recall that event. We conducted a patient who had placenta percreta in COVID.
Uh-huh.
We were in all
Yeah.
our PPE and we transfused blood and everything. So I was discussing it with one of my colleagues. So I just wanted to share regarding this. So
And I think so we did that case in spinal anesthesia
yes, ma'am. Spinal anesthesia
because
and one
that was
we did.
COVID, and we didn't want to give general anesthesia to the patients. So most of the cases were done, and they were.
So
Okay,
anyway,
we have a question.
great presentation.
Yeah,
Yes.
we have a question. Naila Imtiaz has
Sure.
asked, cell salvage does not risk amniotic fluid embolism. Can you please justify it?
The different studies they were given, and they said that when these cell salvage, they have said that it does not cause. They have seen in the cases. Cell salvage, it was previously, it was known that they cause amniotic fluid, but they filter it in such a manner that it does not lead to uh, uh, amniotic fluid embolism. And one thing that it is the patient's own blood, there are no transfusion reactions, and it's cost effective in any way, because if massive transfusion, mostly the patient who bleed during massive transfusion, massive obstetric hemorrhage, they definitely get more than 10 transfusions and whatsoever. They can go into trolley, they can go into, so if the patient is transfused with its own blood, then these sort of reactions can be taken care of. And I have gone through different studies. Cell salvage is the choice nowadays. I can share the, the studies with you guys regarding cell salvage. Because in the long run, the filtration and all that is expensive, but it justifies that the patient is having its own blood being transfused. So no transfusion reactions.
Okay. We have another question. What to do when a patient in OT with 8.9 hemoglobin for emergency cesarean section, should we transfuse red cell before surgery or after delivery of the baby?
Sorry, I couldn't get the question. If the patient is in OT
with a hemoglobin of 8.9,
yeah,
and
okay.
we transfuse the red cell before the surgery or after the delivery of baby.
You know, the 8.9 is now what they have given. They have given that you can, the patient is 8.9, she's here for cesarean. The transfusion is only required if the hemoglobin is less than 7. 8.9 is not less hemoglobin unless and until the patient is has got any major bleeding episode, or she is with the placenta previa or accreta, or she has got any other comorbidity. You don't need to transfuse this patient beforehand. You should wait. If the bleeding is normal and it comes to around something like 8 and the patient is not bleeding, you don't need to transfuse them. It's 7. And post-operatively, they have said, I have told you that if the patient is anemic, you will go for the either after the surgery, you can go for iron supplements, or you can inject Venofer. So transfusion should not be given to the patient if their hemoglobin is more than 7, unless and until she is bleeding.
Okay.
And it falls from 7 to, this is the, it's an international, it's a guideline. We people are transfusing in our setup. In Pakistan, they are transfusing the patients. If the hemoglobin is less than 10, the obstetrician, they use to transfuse them. So one thing which, yeah, sure.
Can I say something?
Sure.
Yes, ma'am.
Yeah, thank you, Dr. Sadia, and thank you, Dr. Asiya, for a very nice presentation. There's one thing that I wanted to, two things that I wanted to comment on.
Sure.
Let me bring the second point here first. The second point was about the transfusion in obstetric women.
Patient, yeah.
Patient. So what we recommend is not to transfuse the blood even when the woman is say at term, because if even if the hemoglobin is 7 and she is hemodynamically stable, then in that case we would not like to transfuse with the blood, because if there is a transfusion reaction, which is always a possibility, so we may lose the fetus in that case. Yeah, the blood should be in hand, no matter whatever woman
Yes, the
finds
blood
to
should
be.
be in hand. That I
If she
agree.
bleeds,
You
if
have to have a cross-matched
yeah,
blood
exactly.
present.
Yeah, exactly. If she bleeds,
But if
take the baby out, and if she bleeds, you may transfuse whatever number
you
of
may transfer,
blood
you
is
can,
needed.
you can.
The 1
But
point.
even if it's more than 7, you don't need to transfuse. You get it checked from the lab post-operatively. What is the practice here is, okay, when the patient has got 2 bloods or 3 bloods arranged, I'm sorry to say, the obstetrician would say, there are 3 bloods, just transfuse 1, so that The patients should think that they haven't wasted their blood. That
Yeah.
should be transfused. That should not be the, because you don't know, you can end up in a transfusion reaction because it's not that the patient's own blood, it's, yeah.
May I
Yeah.
add something here? May I add something here?
Yes, please, sir.
Ji. See,
I just wanted.
so whenever somebody tells me that this patient, there's blood out there and let's just transfuse it, I give them a story. And I would like to share that story with all of you, just to emphasize a point. Because generally, when the surgeons kind of insist that we transfuse just because the blood has been arranged, we tend to give in and we say, okay, here was this patient who actually was 40 something years old, beyond 40 years old. She was
I
actually
remember.
working as a gynecologist in one of the
Gynecologist. Yes,
peripheral
yes, I remember.
districts. And she actually uh, uh, didn't marry because she was taking care of her siblings, and when they got married and all, so at that point she said so she decided to get married, and she had fibroids, so she came to us for 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 this myomectomy. So they did the myomectomies. They had arranged 2 points of blood. She lost some. We transfused her one, and she was okay. She was doing fine in the post-op. On day two, she was about to be
Can't hear.
discharged. She was discharged, about to be discharged when the surgeon went in to see her, and she asked him, "Doctor, Sahab, I've got one blood remaining of that was donor. So what do we do with that?" And the surgeon very casually said, "Okay, get it transfused." And they got it transfused, and she developed trolley. And twice we weaned her off ventilator, and twice she went back on ventilator, and ultimately she did not survive that severe lung injury. So that is something, a story. Whenever some surgeon comes to me and says, should I transfuse below 7, above 7, below 10? So I always say, let me tell you a story. And most of the times, by the end of that story, they are scared enough to say, okay, so let's just hold it. So it's just that uh, one point that I wanted to add to Dr. Asiya, you brought up an excellent presentation, not because you talked about blood transfusion, because you talked about preoperative anemia during pregnancy. Because generally, we as anesthesiologists would tend to say, so why would we bother? Because we are not dealing with the patients during first, second, third trimester of pregnancy. That's the obstetrician's problem. They are dealing with it. See, we also need to be the advocates of women's health, because at the end of the day, we are going to take care of them when they come and they, God forbid, develop metal obstetric hemorrhage. That's when we would be saved by those interventions wherein the patient's anemia has been treated. So I can just give you one example of our experience at Indus Hospital. We have started this initiative, and we are taking those patients on 24 weeks. We only take patients when they present before 24 weeks, and we actively manage their anemia through dietary interventions, therapeutic interventions, supplemental iron, intravenous iron if possible. And the last quarter reports that we have managed to achieve the targeted hemoglobin goals in 80% of our patients. So this is all doable, and there was not no cost attached to it. Fine. So that's something that we as anesthesiologists should actually be advocating and talking to the surgeons and talking to the obstetricians and being part of that campaign. So thank you for bringing this up.
Thank you, sir. Ma'am, we have a question that is too detailed. How would you manage severe postpartum? Dr. Naseem Javed has asked, how do you manage severe postpartum hemorrhage in a Jehovah's Witness patient, refusing allogenic blood transfusion, balancing cell salvage, tranexamic acid, fibrinogen concentrates while addressing the coagulopathy and alloimmunization risk, given RHD negative status and severe anemia with HB of 6 at 34 weeks? So he wants to know the step-by-step approach for the dosing.
The similar approach for Jehovah's Witness, first of all, the patient should come during the first, second, or third trimester. We will build up their hemoglobin, and then what we are going to do, we can give them oral supplements. We can give them iron supplements. They can take. They can refuse blood, but they can take iron supplements. And when iron supplements, they usually 34, we can give them twice a week and light them, build their hemoglobin. And by the term, it can increase to, I think so, 8 or 9 hemoglobin. And on that hemoglobin, prophylactically, we can give them tranexamic acid. And what was the status of para or gravida? If she's a priming gravida, we have to see the placement of the placenta. What did you say? The placenta, if it's okay, then we can do.
Okay, there's another question. Yes. Are you done, ma'am?
And we can continue the hematamics and all that postpartum as well, because postpartum is also the period when the mother still needs. What we do is we stop all those drugs, the iron tablets and multivitamins that the baby has now delivered, and now she's okay. But she should continue, if she's feeding the baby, she should continue these drugs for 6 months or so.
We have a hand raised by Bilal Tufel. Can you please take his question, or maybe?
Okay, sure. Ji Bilal.
Hi. How are you?
Bilal, I can't hear you. Anyone? आपकी आवाज ना वो हो रही है बहुत.
Dr. Bilal, can you please come again? Because we can't hear you properly.
इसमें एक बात मैं I wanted to add one thing. Since I'm an obstetrician and professor of obs and gynae, Jehovah's Witness, that was a good question. With how many Jehovah's we have in Pakistan? Actually, let us talk of what we have here in Pakistan. Let us not wait for the woman to bleed in the postpartum period. The first thing is to put a hand on the uterus, do a massage of the uterus, give uterotonics, give cytotec or tablets.
Tranexamic acid,
Sublingually, give tranexamic acid. Don't wait for her to bleed. Another very important thing that Dr. Asiya, you very nicely mentioned earlier, that if the blood loss is 2,000, if 1,000, you see in clinical practice, in busy tertiary care hospitals, where one after another woman is delivering, it's difficult to have a measure of the blood, no matter what we do. There were some drapes that were kept beneath the woman to measure the blood loss, but still that is not practical, because with blood, the amniotic fluid also comes up. So it's difficult to measure actually how much she bleeds. So, and then the amount of blood loss is if somebody has ended up in her third trimester with say 8 grams, 7 grams of hemoglobin, for her, even 250 to 500 cc of blood loss would tip the balance towards a disaster. So
that's
this
right.
This is very important, that we should not be okay theoretically, and for exam purposes this is okay, 500, 1,000, 2,000. But in practical situation, we should think that every woman is prone to have postpartum hemorrhage, and let us start the treatment of massage, give her uterotonics, give her sublingual. This thing.
I have mentioned this protocol in my presentation. Yes, these things should be done, and the anesthetist also must know that these should be carried out by the obstetrician, and they go in hand, the obstetrician, the anesthesiologist, and the hematologist, and all that. It's a team, so it's a multidisciplinary teamwork if there is a major obstetric, and that is the unpredictability of the pregnant female. If she has got even no risk, and you said nothing, no placenta previa, no abnormality, but shall suddenly any normal gravida or can bleed, which you never know, without any risk factor. So you have to be prepared. Every time you should think that whatever patient is coming to you, she can bleed. You have to make necessary arrangements. But in the patients who have got, PPH and history and multiple gestation, diabetes, abnormal placental, in that way, you are well prepared beforehand. So there are different protocols, but we are not going for component therapy. We are in Pakistan giving whole blood. And you must have seen that we have saved so many patients without giving those component therapies. Exactly. The whole blood contains everything. When you give them component that is from different donors, the whole blood is from a single donor. So you are not keeping the patient into, the bleeding tendencies and hemolytic relations. So whole blood, I think so, in our setup, we are okay. Okay, dividing them into components costs a lot. And we cannot, afford that in Pakistan, especially in the government setup. Exactly. Even public.
There's something I would like to add here, if I may be allowed.
Yes, sir, please.
Yeah. See, about talking about whole blood and component tests, I'm a great advocate. If you got a patient, so the way it normally works in our society is that we don't have those big blood banks. So patients, we tell the patients and the families to arrange blood. There is some blood in the. So if you are if you know that you are going to transfuse this blood within next 24 to 48 hours maximum, then I suggest that you keep it as whole blood. But if there is a chance that this blood is going to be not going to be kind of transfused within next 48 hours, then it must be stored as components, because that's what increases the storage life.
Yes, please, Bilal.
Dr. Tufail Bilal, you can actually unmute.
Can you
Yeah,
hear
sure.
me now?
Yes, we
Hi,
can.
can you
Yes,
hear me?
yes.
Hi, hi.
Hi.
So I don't know what is time over there. Very nice talk, and it's very pleasant seeing you both.
After a long time, isn't it?
After a long time, and
Yeah.
it's worth to mention that Dr. Asiya Taqi was one of those who opened the door, and she was my first supervisor in Pakistan. So I would it's a great talk, but I want to add few things, though it's not practically possible in our countries, but it's worth to mention because a lot of trainees, resident, junior faculty is, I think you have a reasonable number of audience. If you give me few minutes, I would like to add few points.
Sure.
So probably what I see that if we talk about massive hemorrhage in OB patients, you already mentioned that OB patient are not normal healthy patient. Every pregnant lady at term has one foot on the earth and another in the heaven, and they are rock stable during monitoring, and all of a sudden something happens and they collapse. So most unpredictable complication is AFE, and I know that it's such a terrible complication that sometimes we are unable to save both lives. Either baby goes, and the most helpless feel for a provider that someone walks on your table and after an hour or two they are no more with us. And a lot of people get secondary victim due to finger pointing, and they keep blaming themselves. So especially in AFE, that's such a terrible reaction that when we cut someone's body and our own body reacts to own fluids, that in AFE what happens, heart stops due to that
I
massive
know.
embolism, and the
Yeah.
cytokines come into action, and DIC and clotting go side by side. And there are few points. The first thing, it's very important to identify the situation and escalate the care and get involved multidisciplinary people. But we should always consider if resources are available, and we talk about the standard of the care, that what is role of rapid transfusers, what is role that we are unable to get the lines, and what is role of putting IO line, intraosseous lines, what is role, how to involve other people, like what is role of ECMO in this situation, what is a role of, if we are talking about the rapid transfusers, so which line we need a wide bore lines in the neck or peripheral lines, it is very important. And of course the MTP should be activated, and this is a different debate to talk about the component therapy versus the whole blood transfusion. And people were talking about cell savers. Again, cell savers can reinfuse uh, quite a handsome amount of hematocrit back to the patient. But again, question is that the cell saver person is using which anticoagulant? Is it CPD or heparin to keep the blood, being save blood
Yeah,
from
yeah.
clotting in external circuit? Because again, if someone is bleeding or in DIC and we are giving the blood who
Sure.
has already got a reasonable amount of anticoagulation, is it going to be helpful or not? So these are all few thoughts which should be reviewed from case to case. And when to call for cesarean hysterectomy, what is the cutoff level in our institution and abroad, right? So these are few things that we need to talk about that. And honestly, this I have been through one AFE in my career over here in the West, and that was the most terrible feeling which I ever felt, because I have experience of massive transfusions because I have been doing a lot of liver transplants. So point of care of testing, ECMO. So we can bring these modalities to help us, but sometimes nothing works out.
Works
So
out, especially in
what's up?
AFE. I
Yes, in
have I
AFE.
have
And
encountered one case of AFE in my
so your
life.
patient survived or no?
No, no, no.
Okay. So this is such a bad reaction that, and there is
Yeah.
no chance that you can predict that. You cannot label that
You
this
cannot so
patient
that
gonna
is
have
the
AFE and
unpredictability
yes.
of
So if you
I told you.
go on the literature, they say maybe cesarean section or advanced maternal age is a risk
Yeah.
factor. But even people develop AFE after delivery of placenta, and they are not, very old patients. So I think if massive transfusion happens, debriefing is very important.
Yes, to the
All the
family, to everyone.
multidisciplinary people present on the site, they need to meet and review that how system can be improved, right, in the future. And second thing is that in our culture, we never think about the secondary victims. If somebody has a table death due to massive transfusion, how helpful or how efficient is the system to give confidence to the people that it is not you? You were just there in a wrong time and wrong space. You were just doing your task being done. If you are not there, maybe another provider is there. So I think it is also important, and it is also
because it's
important to
an
do a
unpredictability.
yes,
We
yes,
always
yes,
counsel them. Okay,
yes.
anything can happen. You are crossing a
Anything can
road. You
happen.
never know what's going to
Yes,
happen.
Thank
So
you,
that's
Dr.
yes.
it.
Bilal. I
Thank
think you have very
Okay.
rightly summarized all the points. And Dr. Yasser has also mentioned that we can actually use level 1 infuser devices, which are actually simple and very much
Yeah.
effective. And likewise,
For
rapid
the
transfuse infusions does not need any
yeah.
necklines. They can be given via the 18 gauge
So
cannula.
maternal obstetric
Yeah.
hemorrhage is another topic which can be discussed. I
Later,
can,
yes.
incorporate that into this.
We have lined
Yeah.
up these topics later
Yes,
by some
that's
other
what I was
speakers.
saying. Okay, we have to,
Yeah.
a
So
different talk for
So in the
that.
interest of the time, I think we are running out of
Okay.
Yeah.
time, but
So I
maybe
would
we
like
can
to
take
request
one
that we
minor
should
question.
talk about AFE someday. Maybe
Maybe,
few
maybe.
Sure,
people
Thank you
we'll
so
sit
do
much,
it.
over
Dr.
there,
Bilal.
and one
Yes,
of us
thank you
sit
so
over
much.
here and we talk about it.
Right.
Okay,
We will
sure.
do that later. So there is
Sorry.
another question, which is, does blood always need to be warm before transfusion? That's our last question we are taking, and then we will just finish our session. So Dr. Asiya, the
Yes,
question is.
we should. We have got warming devices in Pakistan. They are available. Otherwise, we can improvise our own. Cold blood should
That's
not be given
absolutely
to
right.
patient. Yeah,
That's
correct.
absolutely right. By
And they're not
device,
that expensive. Otherwise, we can improvise. We can put
yes, and
them
by
into the,
improvisation, Dr. Asiya means that
the
we can actually warm
simple,
the saline in
the
the
drips.
yeah,
You can
exactly. And then you can use
hang
it.
yes, you can use it. And don't give them cold blood. That is not advised.
So thank you so very much, Dr. Asiya. I'm really
Thank you,
grateful to you.
Dr. Asma. Thank you so much. And I'm thankful to
It
PSA
was such a
Karachi
nice
for giving
and
me.
extensive talk of yours. Every recent guideline has been touched, and that's the
Yeah.
main aim of ours, that we can actually promote the latest guidelines and the latest updates on a specific topic. So I would again request everyone to please fill in the feedback form so that you can get the e-certificates. And I really hope to see you in 2 weeks' time with another topic and another speaker. I'm really grateful to you, Dr.
Asma.
Asiya,
Thank
for
you.
giving us such an extensive talk. Thank you so much, everyone, and have a good night. Thank you.